o te whatalo whatu, malo whalalo le whafunga le tunu ni tai au. O le whisui ingo tato polkalame, mato whatasi fo I ma scientisi, mai le American Institute of Research, I taltano fo I polkalame pei o na whasalalawina atu mua. O le tai au neo mato whatasi ma Dr. Rob Wine-Cove, e whape fo I malo Brian Duffy, I taltano atu mata upune o kanisa, tasine mata apolo to tele atanga tolo a fiai. Me sidi le umola no taltano ai. Talofa, good morning. Welcome to Samoa Capital Radio, Dr. Rob Wine-Cove. Alofa talofa tulo fioma.
Talofa fioma sang. Talofa payaman malo tato no moment me tula tato te mapu taima tato no tulang a fianga so ko malo ina me swali ne fama el canes. Talofa la fioma sang.
Rob, it's a pleasure to host you on Samoa Capital Radio.
Talofa lava. Thank you very much. Thank you so much for the opportunity to be here today.
I like your aura. I think that the lace fits you.
Thank you. Yes, I'm going to have to get one. It's beautiful.
Doctor, given this is your first time in Samoa Capital, might pay if you're useful if you talk a little bit about yourself. You know what you've been doing leading up to where you are now.
Yes, of course, happy to. So. I've been living around Wellington for about 12 years now, and I'm a doctor. I'm originally grew up in Britain in the United Kingdom, and I trained there and in Germany for a year.
Right.
And then I came here about 12 years ago, and so I've been here for quite a long time, bringing up a young family here. And I'm a medical doctor. I'm actually a blood specialist, so I treat mainly cancers of the blood. Although I'm happy to talk about others as well. And I have a role where I work half the week at the hospitals, so half a week working at Wellington Hospital and sometimes at Keneparu Hospital. And I work half the week at the Malgan Institute, which is the research institute. So I have a role that combines doing some medical work with some research work, which is a great privilege.
Which part of the week do you enjoy most?
I like the combination because you see, when we're working in the hospital, everything is a series of troubleshooting, quick.
Right.
You have to make quick decisions and work very quickly. But at the research, you have to put your mind to big long-term problems.
Yes.
And it's nice to have a little bit of both, because the long-term problems, sometimes it takes a long time to find solutions, but you go into a clinic and you always feel that maybe you've helped somebody that afternoon. So it's a nice combination.
Perhaps that research part gives you time to reflect on the quick decisions you had to make earlier on.
Very important. I'm sure you're absolutely right. And also the quick decision stuff tells you what the direction for the research needs to be, because we're in an institute of medical research. We want to try and make sure that the research that we do goes on to help people. So I think it's a very fruitful combination.
Thank you. I'll just try and translate this as we go through for the audience. O le vaenga pe on whatalo whatule sunga o le Dr. Rob Wine-Cove. O i o se fo mai whapito le kanesa o le toto. E ngā lua I nisio taimi Wellington I a tono nisio mai mō mal taimi nei o wheloa I ai. O isi o taimi nei kene puru whalma I pō rua. Awhana al vai aso ngā lua I whapena a o lisi awhal vai aso o Yale American Institute of Research. O Peltania su mai ai, malanga mai ai molona ainga, sfulua tau sanga tanu nei laumua. Ia o lela ia tanoanga tai au nei whatatau I kanesa nei pe ona iean susuang. Thank you for that. So I'm just thinking over the 12-year period, you must have seen a big change now with COVID-19. You never thought that you'll come across COVID-19 in your travel. And you're caught up down here when they were struggling overseas.
Yes, I was caught up a little bit. We were talking earlier about how difficult it's been with people traveling because of all this. A lot of the doctors that I trained with and went to university, medical school with, got caught up in the UK, and they've had to change what they're doing and work on COVID wards. And I've heard some pretty bad stories about what it was like there. So I think we're very lucky in this part of the world, at least in New Zealand and Samoa, to have low numbers of cases and to have the opportunity to get vaccinated before we face the same things as have happened in some other countries. So I think that's been something that's affected me, and my father was ill recently, and it was obviously difficult to go and travel to see him. But I suppose many people have had much harder times and are still having much harder times with this virus. So yes.
All right, let's go through some of the cancers. You probably are aware now with your background, the number one cancer killer in this country, in New Zealand.
The number one in New Zealand that actually of fatal cancers is actually lung cancer still, and that's almost usually still smoking related. So, and in fact, my father had lung cancer recently, and was treated for that. But it's still the number one cancer killer in New Zealand. It's not the only thing that can be very serious, but it's one that is probably mostly preventable, and it's one that I think really important that we continue to work on trying to find ways out of cigarette smoking if we possibly can.
And the cancer that you come across in your visit to the hospital?
So what I mostly treat is cancers of the blood. So our blood is very interesting. It's the cells in our blood are the cells of our immune system. So our immune system is there to help protect us against infections, including things like COVID, but also bacteria, parasites, all those things. And sometimes those cells of our immune system can actually themselves become cancerous, and that's the type of cancer that I'm mostly involved in treating. And when you take all those cancers together, they're actually quite common. They're actually probably the third or fourth most common cancer in New Zealand. It's just that we divide them into lots of different types and lots of complicated names like lymphoma and myeloma. But together, taken together, they're actually quite common conditions, and most of my job at the hospital is involved in treating people with those conditions. Yes.
When people take blood tests and then they go and check off little boxes there, obviously they're looking for things, and that's how they normally come about, find out what's...
That's right, yeah. So the types of blood cancer often picked up when people have blood tests. Sometimes they cause a growth that people notice, a lump somewhere. But what I would say is that for most things, I think if there's some symptom that's very unusual, and it goes on for more than a few weeks, it's usually a good idea to try and get this checked out, whatever it is really. Blood cancers aren't necessarily the most common, and we can usually treat them whatever stage they're at, but particularly if we're talking about things like lung, if you're coughing up blood, or you have unusual shortness of breath or cough and it goes on for a few weeks, best to get yourself checked out, because and we talked about how the question was about these killers, but the reality is that we got better and better treatments these days, and most people don't die of a cancer nowadays in a country like this, so we can treat them very well, and it is worth getting symptoms checked out.
Growing up a few years back, when people talk about cancer, it's like a death sentence. But now it's changing a bit, because people are not getting to be well informed, and
it's changing a lot.
And treatment is there for most.
That's right. It's quite uneven, because there's still some types of cancer that unfortunately we don't have fantastic treatments for, but there's many that we do. And there's two things that have happened. One of them is that we've got better at detecting them early and curing them for certain types, often with surgery, but sometimes with radiotherapy or chemotherapy medicine. And then there's other types of cancer that we can't necessarily cure, but we can control them for a long time, often for many years with medicines. And then it becomes more like a chronic health condition, rather than something that's a death sentence. So I think we've got great treatments, and they're improving all the time. And the other thing I just reflected on when you mentioned that is, when I was a junior doctor, we were taught, if you had an elderly patient, to never say that they had pneumonia, because for an elderly person, if we said that they had pneumonia, they would think they were going to die. But if you say a chest infection, they don't think that. And that's because many years ago, if you had pneumonia, we didn't have such good antibiotics.
Right.
That was often a sign that someone was going to die. And I think that changed with our antibiotics. Usually, most people will recover from a pneumonia, mostly. And I think we're moving towards that now with cancers. So hopefully it's changing. It will still there's still a lot of work to do, but there's been big improvements just in the time that I've been a doctor.
Right. Thank you. Ole vainga le pena fasili le polel kanis numero tasi ni New Zealand. Ole lung cancer po mama kanis on mama. Ole vainga pe ona ela nga luenga ne susu enga ole kanis ole toto. Ole simena lenta ua e tele ina fama faila nga luenga. Na fasili fo le tulanga ile pe o tato e fefe pe ata ole le kanis intangata pe o madiu. Ya au taluai rana isa no anga taluai ole le ia tong fitinga ole toi maua I ale lana I ta ua fo le fa ma ile maua isi ole pneumonia a ta ulo I pe ona ia of to a matala na ia a onga fa fo mai e pe fe tangata e mali di ungo fie ile vaenga lea ia ai o termine le wa amatana le ia tato tong fitinga pe ona ia ta ua I treat myself for ye ole wa mana ye le tulanga we ta to terminate. In this country, probably some states you came across, how many people die of cancer?
Well, in this country, the New Zealand Cancer Registry actually records all the diagnoses, and there's about 25 or 30,000 diagnoses of cancers a year, and then about 9 or 10,000 people a year thought to die of that. So it just shows that maybe most people don't die of it, but it is the most common single cause of death. It's become a bit more common as a cause of death in New Zealand now than heart disease, and that's because we're getting better at treating heart disease, and so we're getting better at treating and preventing the other conditions. So this is becoming more common, and unfortunately, cancer is a condition that gets more common as we get older, and so as people's other health improves and we live for longer, we can expect to see more cancers, because the more time we've lived on this planet, the more chance our body has to have seen things that might cause cancers on ourselves.
And the lifestyle, change of lifestyle. Some of us come over here and then all of a sudden we're eating different food.
Yeah, for sure. I mean, so there's some obvious things that are high risk, like smoking. There's some things that are less obvious. We have to be a bit careful about, like pesticides, the Roundup that you spray, and have to be a bit careful to put the gloves and the mask on when we're doing that. There's certainly things in certain fried foods that can be a risk factor, and there's also some simple things like sunlight and X-rays and things around in our environment.
You mentioned the sunlight, and I see Consumer New Zealand been doing a lot of research on the sunscreen and the effectiveness. And
oh yes, it's always very interesting when sometimes the best sunscreens are the cheapest ones. So check what they recommend.
And then I was just thinking about the socioeconomic, whether it features in how cancer affect people low, socioeconomic in the country. In any of the research, do you find any of that?
Yeah, so it does. So the first thing to say that can affect anybody, and there's nothing that really completely protects us. But if you look at the rate of dying of cancer based on somebody's age, it is higher in people in the most deprived groups, and in the way that the New Zealand statistics do it, they make this special number, this index they call deprivation. It's not just how much money you have, but it's also if you have access to a car, if you have access to internet, if your home is overcrowded. It's all those things put together. And what happens is that for some cancers that doesn't make a big difference, but for some cancers it makes a very big difference. Lung cancer is one where the rate is much higher, and again that probably largely comes down to cigarette smoking, but might also be other pollutants in the environment. And there is some link in that with things like breast cancer and cancer of the womb, the uterus in women. So yes, there is a difference, and I think that roughly speaking, people in that lowest income and highest deprivation group are probably about a third more likely to die of cancer than people in higher income groups, and there's all sorts of determinants of that. Right. Probably partly exposures to things, and also partly access to healthcare and cost of having X-rays and things like this.
Thank you. Ole vainga pen matutan no ia I tulang ole afianga tangata ile kanisa mo i lātou ia le tongi maulalo. I o leo sau noi Dr. Rob. E de o whailonganga whapena le tele o fususu engam whamomonga. E taito tusa o mai tangata umea a whirikane sa vanga nai e isi tūranga e loa i pe o tangata e maulalo tongi e maulunga le numera e mo le kānesa. A pe lusu lima awhi tangata e mo le kānesa i tausanga. I be iwa se fulu afe I to mali liu. I'll just reflect you on the numbers you gave. 25,000 that got cancer a year, about 9 to 10,000 get for our listeners. E lisi tūlanga pionta ula tōle mo le kānesa o le mā ia o le tele o le ulula a tono o le wheo tā oi na ia tā whia le ulula. So our people who are heavy smokers, they need to look at their health. They have to give up the cigarettes. So just relay that message.
Very, very good idea. I think it's an important one, and I know that there's this new government agency, Te Aho or Te Kahu, the thread in the cloak, has a big focus on trying to standardize the national treatment and diagnosis pathway so that everybody has the same access to the tests that they need. And there's some things that work well in the healthcare service and some things that are a bit more difficult. I know we have some patients where it's a real problem to go and be told you need an X-ray and then have to pay a lot of money for that X-ray. And so some of these things are some of the very important paths that they're trying to look at to see what they need to do to make sure people get diagnosed at the right time so people can get the right treatment.
And that's where I guess the cost factor comes in. Because if you can't afford it, then you can't turn up for your appointment.
That's right. And if you can't, I don't know how much you find this personally, but I've some patients who just find it very difficult to get the time off work to come to the clinic.
Yeah, that's come through some of the programs we've done.
So what I do with some of my patients that just really can't get the time off work, because then I do a telephone appointment, give them a telephone call at the end of the clinic, get them to do the blood results, and say, well, I'm still happy to check. For my specialty, often the most important thing is the blood results and then the prescription. I can often do that by the phone, and that makes it a little bit easier, or even sometimes by text message.
So how do you relate the message when it's one of those bad messages that you have to, unfortunately, give to a patient?
If it's bad news messages, then we actually had some training on that when I was in medical school. We actually got taught about that, and I think it's recognizing that you can't try and make a bad message good. I think maybe there used to be a time in medicine where we just would try and pretend that things were okay, and I think that just makes people more anxious and more scared. And those discussions really have to be face to face. We have to bring people along. We try and encourage them to bring a support person, and we try and give them time to have those discussions. But it is difficult, but it's a very important part of what we do, and and also we need to be frank with people and honest with them, so that we can negotiate what the next plan is, because we can always make a good plan, even if the outcomes aren't that good. We can work together to find a way around things.
I've actually been summoned to come to the hospital. One of my relatives was diagnosed with. So that's exactly what happened. We were told the facts, and they told to be prepared for certain circumstances, and outcomes. And we walk away happy because now we know it's the truth.
Yeah.
Rather than be given something which is not exactly correct, and then you find out, and it'll be worse.
I agree, and usually, often people know before you tell them. Really, it's just not been voiced. Often the patient will know a lot more about their health than they're prepared to admit, and somehow saying this actually can actually lower the level of stress sometimes. That sounds awful, but I think it's true. I think we need to know and understand so we can find a solution.
Thank you. Vainga ia pe matatal no ne tulango o ngase ia. Ile whainguta I si taimi pe ata o tangata le tulango i ele kānesa pe se tulanga le lei po le ta whatsapp. Ia pe usau no Dr. Rob Winecove o le ta usawa o le tulanga o ele ngase. Mawaso ni wotele ina mawhai o na ito mawhiti e wha le lei ai pe to e wha whaingo fiele ngase tangata i le pe o taimu mua. Ia pe o vainga ia ta wotele Hello, today Lopez Vanga to fear for Popo Ivan. I just want to bring Hello in to see if I missed any of the things I've been trying to verbalize in Samoa.
Le o ma ia wa ai pengofia le ia kulanga ka mo no wa.
Late noise. I'm on right track, so I'm in. All right. So, what are the signs of cancer? When I look at somebody here, do I know if he's got cancer?
We can't know what we've got, but I think it does differ according to where it is. But I think the important things are to know your own body. We will all get sick sometimes. We're all going to get a cough or a cold and, a pain here or there. That's going to happen. That's normal life. But if something's getting worse and worse over a period of time, over a number of weeks, say, and there isn't an explanation, it's a good idea to seek out some advice. And usually the symptoms of a cancer are going to get worse. So I'll just talk about the ones that are most common. For lung cancer, coughing up blood is something, if it's coming from on your chest, yes, it doesn't mean it is cancer, it could still be a chest infection, but that's usually always worth seeing a doctor about, even if it's an infection or blood clot that needs to be looked into. For breast cancer, New Zealanders are encouraged to examine themselves. New Zealand women are encouraged to examine their breasts, and there is a screening program, Breast Screen Aotearoa, where women can have regular x-rays, mammograms of the breast every 2 years. Those are free.
Yes.
And we very much encourage that. I think it's between the age of 45 and 70.
Yes.
And similarly for women, if they start to have bleeding after the menopause, so if you have blood loss years after your periods have stopped, that's a bit of a concern that should be checked out. But I think it's really just knowing your body and knowing where symptoms are new, and especially if they're persistent. And often, in fact most of the time, that appointment will turn out to be okay, and it'll just be a reassurance, which is great.
Right.
But I think it is important to check these things out.
Ole vainga ta wole mo fa fonga ngale tunu le le siri nei ai. Fa fena I loe mo tanga tel kanisa. Ni va inga te sira fia. E pe ona saunole scientist. E ese va inga fa ingo fio nei loe. Ai ese ai loe tanga telo na tino a fa pe uti nga isi taimi fa solo to ama umi. Yo lo no inga tauna sia ke ese me olo fa le tonu ai. Ya pe na ita wa o le test fo le ta to mo le toto o le mfa inga sia ke na mo wale o tulanga o mena fa ma ni ai. Ya ai tau ona por tulanga o le mama. Ai tale mai ai sa o e mali toto se tu lo le fa fa ma le tunu ia o le siva inga na va ai. E le fa pela o mo o le kanisa. Ai vai a tonu se va inga na pe o mo e tonu se infection pe na ita o. Ia pe siaki ona mo wale o tulanga na. Ia ona mai fa ina ia o stong fitinga. Can cancer be cured?
Yes.
Oh, good.
Well, the short answer is yes, in that most cancers, in fact, most cancers are cured. Most cancers are cured through surgery, even if that's removing a skin lesion or a big operation like on a breast lump or a lung cancer. So, yes, many cancers can be cured. Some types of cancer can't be removed by surgery. For example, cancers that are there in the blood, like a leukemia, they're all over the body because they circulate in the blood, so you can't cut them out. Other types might have gone to other parts of the body, so surgery isn't the right approach. But some of those can still be cured through particular types of chemotherapy or treatments like the kinds that we're working on. And even the other cancers that can't necessarily be cured, some of those can be controlled for a very long time, often many years, sometimes decades. There's some types where there's simple tablet medicines that can control them for a long time. Other types where that might just need to be treated intermittently on and off every few years. So it's very variable by the type, but it is important to know that we have very good treatments for most types of cancer. And as for whether your own or your family's type of cancer can be cured or not, that really depends on the type and where it is, and that's something for the individual specialist to answer.
Thank you. O le sini tu ina tuai pe mwhai o na tong fitia le kanesa o le tali ioe. A yeisto inga kanesa whaingata o na mawatonu se tonga fiti mautu. A yeise me whai o na tong fiti ia o na umia le o se taimi te soifua ia ai vava ai eiva ia tūlanga fo i molona vainga. Ia atonu vainga na whire mau e tātou. O le si vainga le i o fasiri lea. Sa tana noi mo le pre-screening, mo le cervical screening me whapena. Ia o vainga na le whaika nesa o tātou. You mentioned pre-screening earlier. We do that quite a bit in our health programs.
Good.
And all the ladies are encouraged to go and get checked out. So it's part of what
Excellent.
and we've been doing that since 2010.
Excellent. I'm very pleased to
So we've been doing a drive for all our ladies to go and make sure that they're checked and
That's an excellent idea.
So thank you. We'll take a break here and then we'll come back and we'll go into this other topic. I really want to talk about the treatment that you're leading. So e whatalo whatu whawhonganga le tinu umatu whatasi put whasala lau tai au nei ma Dr. Rob Winecove e whapea mahalo Brian Duffy tau tana noa tūrutu i ngase ne o kānesa. O le vaenga nei la ma tau tana noa si tasi fo i utong whitinga ia o uma o no i le lato sa ili ili ngā ma o whiwhia fo lato e tana noa ni ta upune taimi nei. Thank you for the early part of our program about the topic this morning, Doctor. Now that I understand the American Institute, end of last year, 2019, or is it 2020, you discovered some groundbreaking cancer treatment.
Well, we are working on a new type of cancer treatment, yes, and this is in collaboration with other researchers as well.
Yes.
And this type of treatment actually is a relatively new way of treating certain types of cancer. And what it involves is taking patients' own immune cells and reprogramming them so that the patient's immune system cells now recognize the cancer cells as foreign, and then giving patients back those immune cells. So it's quite a sophisticated new way of treatment. It's got a name, CAR T-cell therapy, and we've recently established the systems so we can make that type of treatment and conduct small trials of that here in New Zealand.
Alo, amul tal no bai ol bai ngale now pass on to Alo about all this technical terminology.
Yeah.
Ya, papai, ya. Fa sa mo ole tulanga le wo e ole su fe ngamato e fa ngamo le tuipui le kanesa ono pe o tele o to mo fa ngamo vai la au ya pe la o pe si fita po kala ma e ole o to ya mani vai la au le lo fa il tulanga fo le o katisa o tulanga le wai o atono tulanga le na la fa ngata no mo se fo o na o whaonga e tati tonu whiti o whaonga o whātutu sa o matata unga ai lea i o le whasa unga e se u matata me la whae to koe rātou ma e se mi o le makore lima tulanga la na leo whaisu so enga ia e tue au mai a vai ngā le pui ngā rau tino e mai te whae tu te fufuanga an toi tūle tonu le tino ina ia e doa le tino o lana vai ngā rau tonu pero tulanga na o so se ngā foula nei le o umale ia tama whainga male so se ngā i le luafe sui le la whamani le tau si la fie i atanga o matua le ankane so o mai na whamaina i tulanga na le tau e rock
really whaftai Rob, so I was just listening to you take a blood cell out, you reprogram it and put it back in my body. How safe is it?
Well, that's what this first trial is to find out. But actually, we've done this trial and developed this treatment quite similarly to other treatments that are used in the United States and Europe and China. And so we know already quite a lot about the safety of the treatment. But because this is the first trial of the cells that we've made here in New Zealand, in Wellington, it's a very safety-based trial. So we started off at a very small dose of the treatment and work up gradually with lots of very close monitoring of the patients in the trial. And perhaps later this year, we hope to be able to treat people faster because we already know quite a lot about the safety. So the answer is actually, it can be quite safe actually, compared to, because the only people taking part in the trial have had a type of lymphoma, a type of blood cancer that's come back multiple times, and so they've already had quite a lot of more intensive treatments before that, like lots of different types of chemotherapy, and so far we think quite safe, but of course this trial is still going on, so I don't have the final results to explain today. But it's we think it offers a very good alternative to some other treatments for certain patients.
I don't know, when we came for a guided tour of the American Institute, when we got taken to where all these mice were, just wondering whether this has been tried out in some of these mice, or is that
not here, no. And actually, because this treatment is based on human cells, this particular treatment is quite difficult to test in mice. And there have been other studies in other centres that have tested this in animal models, but for this particular treatment, in fact, you can't really assess it in another species. You have to. It's a personalised treatment. And just to talk again, there's these cells in our body. They circulate around our body. We have billions of them in each litre of our blood. And normally, what they would do is they would recognise cells of our body that have been infected by a virus or something like this, and they would kill those virus-infected cells. What we've done is we've reprogrammed them so now they recognise the cancer instead. So we're kind of using the patient's own immune system against their cancer. It's actually quite a targeted therapy in a way, because, and it's in some ways it's more targeted than some of our chemotherapies that we use.
And so the blood cancer you've been testing this on, what are some of, you mentioned
it's the initial trial is for a type of cancer called lymphoma, which is a cancer of the lymph glands. The lymph glands are where, like around the neck or in armpits, and this is about the 8th or 9th most common cancer in New Zealand, and this is the type of cancer that seems to respond quite well to this new type of treatment. We hope to assess this type of treatment out for other cancers in the future. Even though we're quite a big research centre for New Zealand, we're quite a small research centre by the comparison with some of the ones in the United States and Europe. So we can't test everything at once. So we're looking to our partners in other countries, see where they see any promising data. We can come and assess those too.
So you've done the first trial?
We are currently in the process of the first trial. And
You got various generations. You're
That's
on
right.
about the third now?
Yeah, so this type of treatment is actually routine now in some countries,
Okay.
in the United States, in Europe, in Australia. It's not funded or available in New Zealand yet. And of course, I'm a doctor, and reality is that one reason we do clinical trials in New Zealand or in any country is to make other treatment options available that aren't yet available here. So this is part of the motivation for us to want to do
Right.
this study here. But of course, we can't just take the drug from another company and steal it. We've had to try and redesign the CAR T cell treatments and improve on them, so that not only is it justified to do the trial, but there's a strong scientific reason to say, oh, hey, this could be better than what's out there in other countries. So we've redesigned the CAR T cell treatment, and this is a so-called third generation. So the ones that are being sold for a lot of money in the United States and
when I was doing
Europe
the research.
are second generation products. This is third generation. Of course, we don't yet know whether this is better or not, but we have reason to think it might be, and that's part of how we're justifying doing this trial. And so far, I think we've got good reason to continue to do this.
When you embark on doing this research, how hard was it to reprogram yourself to do exactly a focus or target a cancer?
Took quite a long time to work this out, because that was a big new part that we hadn't done before. But we knew what way we wanted to do this, and actually, oddly enough, everything comes around and goes around. We actually use a modified version of a virus to reprogram the cell, but a special type of virus that can't make copies of itself, so it's
Right.
incapacitated. And this is the part we hadn't done before, but we had partners overseas in China and Germany that helped us with components of the treatment, and we put out an advert, and we were very lucky that there was a doctor originally from Italy, a research doctor originally from Italy, but who'd worked in the United Kingdom and America doing exactly this, and she was sitting in Miramar in Wellington, twiddling her thumbs because her husband was working for Weta on movies, and she didn't have a job, and she was looking for work in that area. But she had great experience, and she helped us set this up. So we were quite lucky. But now we've got this set up, the way of doing this gene modification, and we've been able to confirm safety of this, and we also had to get this through all the regulators and who also checked all our paperwork and everything we were doing. We're in a good position to do this in the future more.
Which is to ask Carlo to try and translate this for us.
Sorry.
Ia papatai ole tūlanga le e whaonga mātou e ana tāua. E a mai a ia me o sele pe o tātano e sele o tino. E mai e toe o tūlanga le e whai o tangata. Me nā ina whai ngō le si ngai le kāti sao. E a mai la e toe ngā lua i whafo. O tūlanga le se wāinga whai ngō whi. Ona e mō su e mātou po le a whainga mātou po se wafu hona. E su e mātou po le a ia wafu e pipi i le meo o kanesa. Ona mai le tau whai mātou e whaafe tau i le wafu le ma le waare la loa tui. O mena e whai whafo. A whaatai tai lola ia e loa tui. E whi tau i le lei. Tūlanga nana e upe o whaamauni e tūlanga ia. Ai ole mi o tau whapasenga po a fōlingo le wafu le pipi i le meo o kanesa. Le ala wo mau le tūlanga nana ta o rock le o amatai whai ngō whi le tūlanga.
So when we came for our guided tour, Professor Lacrosse showed, one of the treatment, some young lady, they got cancer, and after being treated, everything seemed to clear. And it was quite amazing to see that on screen.
Yeah, so we've had some very promising results in the trial so far, and we are very much hoping to get the final results of that part of the trial in the next few months, and then we're already planning an extension to the trial. So yeah, I think it's got the potential to work very well. We don't yet. We have to be a bit careful because we're very closely watched by our regulators, and I can't, until we have the final results of the trial, we can't say exactly how successful it is, but we do have promising results, yeah.
So I've got to ask you, how the treatment works. Obviously, you reprogram and put it back, and hopefully it will do its job inside the person. I asked you the question earlier, how do I know that in time it wouldn't morph into something else? Or whether I have a dramatic experience and might get stressed, and then the whole thing gets stressed as well and changes to something different.
Yeah, well, I mean, these are excellent questions, and they're very relevant. So the first thing is, this was a very big question when this type of treatment first came along.
Right.
And in fact, some of the first people to get this kind of treatment were children with leukemia in the United States, and there's a lot of concern about long-term risk. So the first thing is that this type of treatment has been given to many thousands of people worldwide now, and with the way that we're changing the cells, that seems to be extremely safe. The one thing that we do is we ask everybody who takes part in our trial to agree to join an international registry, and that's because it's still a newish kind of treatment. This registry, it's based out of the United States, and it records details of many people worldwide who get this type of treatment, and by doing that, that's a good way of picking up if there are any late side effects that might happen 10, 20, 30 years later. So we have that in place, and we also do some quite extensive testing on the cells before we let them go to be treated to a patient, to check that the cells are what we think they are, and that they work the way they are, and that we haven't altered them too much, and that sort of thing. What I would say is actually, realistically, I think the biggest risk to patients is either their cancer progressing before we can treat them, or the side effects of all the other chemotherapy they've had before, because for this trial, we're only treating people who've had a lot of other chemotherapies before that have failed. So at the moment, the trial is only for people who've had all of the treatments and everything else has stopped working.
Can this replace chemotherapy?
It's a really good question, and there are some trials going on at the moment internationally to say, to look at treating people much earlier with this type of treatment. And so far it's coming, there's some preliminary results that say it might be used as the second line of treatment for certain types of lymphoma. So I think we're seeing that coming, and it will take a number of years before we know exactly where this type of treatment best sits in the pathway. Because I mean, chemotherapy is still critically important for lymphoma treatment. It's always going to be very important. This isn't going to replace that, but it might be that we might get better at working out who's going to respond well to chemotherapy and who isn't, so that we, the people who respond well to it can get the standard chemotherapy, and the people who aren't responding well, instead of making them keep going through something that's not working, we can quickly switch them to a better treatment for them.
In your work at the hospital, you must have come across some people who suffer from blood cancer that you think this would be ideal for the treatment, and yet we can't use it.
Yes, that is a problem. And in fact, it's not just only this, it's other treatments as well. A lot of new cancer treatments end up being very, very expensive. And this is a big problem for us. We try and find the best ways we can. Sometimes we take part in clinical trials as a way to bring access to treatments that aren't funded here. Sometimes we use other treatments. Sometimes we write to Pharmac to ask if they can make a special exemption to pay for a patient. This is a small component of that, in that I hope we can make CAR T cells much more cheaply than some of the commercial ones in the future, and offer this treatment more widely. But yes, it is a problem, and it's not the problem that's unique to this country either. Even in Australia or the UK, even in the United States, what treatment you get depends on which insurance company you're with. And if you don't have insurance in the United States, you get really stuck. So it's difficult.
At what point of your trial and research will trigger for points you say to government? You're trying to get Pharmac to approve all these other drugs, and yet we've got a treatment in this country available for this treatment. Why don't we use this?
Well, we've been having preliminary discussions with the regulators to make sure they're aware of the treatment. I mean, we have to get more information about the safety and how effective it is before we can actually apply to do it routinely. But we hope that after another trial called a phase 2 trial will be the time to do that. But it is very often the case, and it's not just unique to this treatment, that we clinicians, we often use clinical trials to bring access to treatments we don't have otherwise. And so if we're involved in designing that trial, we can try and make sure that it encompasses and makes it available for as many people as possible in the trial in the meantime.
So probably have to get a community to start lobbying for something there to help treat.
There might be a time for that. Yeah, there might be a time for that, and we do work with patient groups, and we are thinking now about if our trials are successful, about how we can deliver it, and we're meeting with the Cancer Control Agency to discuss that. So we are trying to think like 2 steps ahead to how we could do that more widely. But you're absolutely right. It's a big question.
Because I would like it ready before I get my cancer. We'll get out to do a bit of work now. We'll have a little rest. Please translate all that.
Well, le pe ona o tamu fai e whamamala mātu tūlanga lea o le taimi nei so ngai e whai e lai titi ai to ina kānesa le e whamaina ona e mana amia ia i saunga le mu o ona ia fia se so i fua pe o tūlanga i pe so ngai o tuanga a fia se so i fua e uma ina ta ofi lo le vanga de ka o regulators o tūlanga le fai mātou e fai fa solo a fai atua o te resi suinga ia no wale tūlanga i mei o kānesa e se lau li no se lau to ina kānesa e fuafua na i vai mo tino lai mena ala kānesa i e tasi a mātou la pe o ta ua e tatoro o kānesa le la ro au se tūlo pe o tūlanga na le wha mai mātou ia vanga wha mātou a wha pe rotu au wa toto ia na sui foi la io respa tu langa le ta o Europe tende.
So obviously I had the question, is it available for patients now? It's there in other countries. Is that the answer?
It's there in other countries, but not here. Certain types of it are there in other countries, yeah.
So with the 3rd generation now, so have they got the 3rd generation used in other countries now?
No,
this still is where you're at.
Yeah, we're one of the cutting edge trials of this type of treatment. Yeah.
Hurry up!
We're working on it.
Get it out there. I was looking at an analogy of how you got the cars when they were first manufactured. You know, they thought it was a nice piece of machinery, but over years they see it improving.
Yes.
And if you're now on the 3rd generation of this treatment,
yes,
obviously you're looking at further improving the same. They started back in 1950s, I thought.
Yeah, well, certainly the earliest studies were in the 80s, this type of thing were in the 80s, but there was other T-cell therapies before that, be quite right, yeah.
All right, so I had the other question. Can a cancer patient ask for this treatment as a personal choice rather than waiting for a doctor to say, I think we'll have to give you this?
At the moment, you can't. But I think it's always worth asking about what the options are, and just to say that this is one type of treatment, and there are lots of other good new treatments coming along. There's many patients that I treat that are much better served by conventional chemotherapy or by standard tablet treatments that actually are known safety and known effectiveness. So this, at the moment, this treatment is very much a last resort for a small number of people, but that will change, and the good thing is that each time we keep making improvements in our treatments, usually they get more effective and usually less toxic, less side effects, and things are improving. I mean, I've been a doctor for about 20 years, and the way we treat a lot of blood cancers is quite different to what it was when I started.
Right.
And I'm sure by the time I retire, it'll be very different again. And these are all improvements.
So have there been any treatment in your time that been like obsolete, lived out?
Yeah, there are some that we're using less often. Yeah, so some types of treatment are becoming displaced, but usually they don't go away completely, but they get more restricted.
Yes.
Like we like the thing is that cancer isn't just one disease, it's hundreds or thousands of different diseases. It behaves differently in different people. We can now tease out the differences between one and the next and pick the right way of treating them. So we're getting much better at that, and we'll get much better still in the future.
Ole vainga le pe tano ile scientisia Rob. Ole tulanga I tung tinga le pe ona yel temine sa fasidi pe mafai ona fai ngo fifa nga so stangata. Ia taroi o le lalo le trial po le whate ta inga I tuangata. O tele na whaonga I sinu I whafo, ai leo wha mwhai o na whaonga tātou I New Zealand. A le wha moena ina ia tamu whai ina ia vave o na tadia tonu nemi whaatanga. I o na whaonga I lola ia moniso tangata. O le sifisiri, pe mawhai o na e whiri whaonga o le tong fiti lea pa e manatu iai, pe te manao iai. Ia fufuanga whai fo mai whaatasi ma oe pe am whai ele o na whai la tō. Ia o na watula ia o le tong fitinga le iai. Malana saunoanga fo. Luas futau sanga talu o na fo mai. Ia isi tong fitinga sa ele amatanga o le tō whaonga le teimine. A o le vaenga le o tātou e nei le vaenga lona tolu le o le suinga mai le tong fitinga le e tang whai la tō I New Zealand. Ia ele I mawaisi atunu a le o le tō whaateta inga. Mane wha nauno ta inga ina ia mawhai o na wawe pāsia ina ia wha nāi tātou. O le si fasiri, no fasiri ai, pe mawhai o na sui ele chemotherapy le masani tātou pe alwe whai. Ia o le sina waenga mawhai o na whaanga I ele susuenga. Ina ia maua le tonga fitinga tasi a mo tātou I lumana. Ia tātou wha moe ina ia manuia tonga whainga e sosoani a tātou. Let's hope and pray that things will work out for you, for the research, and then we come up with another best tools in your toolkit to help secure the cancer for your patients and our people in society. Rob, thank you very much for your time with us. And when I was reading up the information about this cancer and the T's, I thought, what is this? And then as I got into the all the information, I thought, wow, if we can have this, it would be very good for the future of patients with blood cancer.
It will be great, yes.
Final comments?
Ole ipe ona tau personalized therapy e tau ro. O tulanga na le mana o mia tātou. Wa ese mo tātou pe tulanga tau wala na o so enga nei. E tau le iso so enga whapenei a mese o fo o cancer. E whaonga mai ia vai lo tino se tulo. O le mera na le o manu ia le tino so enga nei. Ona wa ese u matatou. E o tulanga na le tau e rape. If ona relate le so enga nei ona wala o mai ai tino tangata la to le ngasi no to tu le tu ton wa ele ma failante engal tino wa ona ya sele lo to wa ai tu ton au pipi tu la i ton mal mato pinena pi tu ya fa ngol o ka ia fa ngo fie ona fata ma i el tino o le tau ala na su se fa pene a meio kimo ma meio e desi ele se motino hoina banga wala tiki se banga le cancer ona nga le pe fa foto tonga preparation duranga pena.
Thank you. We're doing a big campaign on encouraging our population to go and get COVID vaccinated.
Excellent.
Encouraged from you, sir.
I very much encourage it. I strongly encourage it. I'm vaccinated, and I think we were saying earlier that there are some people in our community, people maybe who've had a kidney transplant, or people who are currently getting chemotherapy, or people who are on other medicines that damp down their immune system, like for arthritis. Some of these people will not respond fully to the vaccine.
Right.
So what we need to do as a community is all get vaccinated to protect, not just protect us, but also to protect them, people with weaker immune systems. And so I think that's really an important message, and strongly endorse that. And I think it's I think it's very important. Feel strongly about it. So thank you.
Thank you, and all the best for your work in our hospitals here in Wellington.
Thank you.
The research at American Institute of Research.
Thank you.
We're looking forward for the live treatment.
Yes, and thank you so much
in
for
the
the
next 12
invitation.
months.
And thank you very much for the hospitality and the invitation. It's
thank
been an
you.
honour to speak here.
Yeah, o tato por kalamena le fo wa fa fo tu atu tato malo fa lo ni tai oni wale kanesa fa o le tu yo covid ya tam fa tato fa ne fo na fa lo ye ni si lo ye tong fiting lo fa yo te mine e le fiang tal fiang ai mo le fa ngol covid ya tu langa na e fa ya ona tato amna ia ai le fo fa mni tato ngadwenga ia ma fo fa mni nga tato por kalame ya tato por kalame nei tato e fero sistema mo te mine mat fa to fa so fua